We're honored tonight to have Dr. John Krohmer with us as a speaker. Dr. Krohmer recently retired as the director of the National Highway Traffic Safety Administration's Office of EMS in the Department of Transportation, and also as the EMS medical director for the Caroline County, Maryland Department of Emergency Services. Dr. Krohmer served as the NHTSA Acting Associate Administrator for Research and Program Development from October 2018 to January 2020. Prior to that, Dr. Krohmer was the Principal Deputy Assistant Secretary for DHS Office of Health Affairs and DHS Deputy Chief Medical Officer. Dr. Krohmer began serving in that position as a member of the Senior Executive Services with the DHS in September of 2006 and served as the Acting Assistant Secretary for Health Affairs and Chief Medical Officer from August 2008 to August 2009. Dr. Krohmer was an attending physician and Director of Emergency Medical Services prior to his government work in emergency medicine resident and Department of Emergency Medicine and the Spectrum Health Butterworth campus in Grand Rapids, Michigan. He's also Associate Professor of Emergency Medicine at the College of Human Medicine at Michigan State University and EMS Medical Director of Kent County Emergency Medical Services and was a Medical Director for the West Michigan Metropolitan Medical Response System and the Region 6 Consortium. Dr. Krohmer received his undergraduate degree at Fair State College, School of Pharmacy in Big Rapids, Michigan, and is a graduate of the University of Michigan Medical School in Ann Arbor. He completed his emergency medicine residency and EMS fellowship at Wright State University in Dayton, Ohio. And Dr. Krohmer is also board certified in emergency medicine and emergency medical services. Again, we're honored to have Dr. Krohmer here with us. And Dr. Krohmer, we want to, on behalf of the McSwain Trauma Education Project and myself personally, we want to thank you for everything that you've done for EMS throughout the years, both in your role as director for NHTSA and also for the work that you continue to do with the EMS Museum. With that, I'm going to go ahead and turn it over to Dr. Krohmer.
Thank you, Steve. That was very kind of you. And the next time we do this, I'm going to change that to 2 sentences and we can move on. I really appreciate it. Do you have the right slide format up in front?
We do, sir.
Perfect. All right. We're going to go ahead and spend a little bit of time tonight talking about non-clinical things that are associated with EMS. So if you're looking to talk about pre-hospital blood transfusion programs or field amputations or the kind of fun stuff that we don't do very often but like doing, that's not going to be it. Mary and I were chatting a couple of months ago and came up with this topic candidly based on my experience both at the federal government level and as state government, because there is a lot of confusion about how EMS relates, particularly at the federal level, but certainly at the state level. Steve has already talked about these, so I'm going to move on. We're going to spend time tonight clarifying the direct federal regulatory activities as they relate to EMS. Talk about some of the historical aspects of that because it impacts where we are now and is very reflective, candidly, of where we are now. And then one of the things I want to talk about at the end is the EMS Compact, because that does impact how EMS clinicians are able to practice clinically when they're outside of their particular state of single or primary licensure. Just to clarify, when folks talk about emergency medical services systems, it really talks about the system from the time that the event is recognized or the incident is recognized through all of the components that you see in the center of the diagram here that compose what we typically think of as an EMS services program. So as you look at this diagram, EMS activities, as we classically think about them, go through the right-hand side of the schematic down to transport and arrival in a definitive care facility, whether that is an emergency department, trauma center, specialty care facility, or something like that. But keep in mind that the EMS system extends past what we typically think of as EMS or out of pre-hospital care into the hospital, the specialty care issues, through rehabilitation and integration of patients back into the hospital. We're going to talk about a couple of historic components that has led us up to the development of where we are now, partly because I think it's good to know a little bit about our history, and partly because it leads very directly into where we are right now. If folks haven't picked up on this, this is the first phone picture that was tried at some point in our history. Anyway, and much of what we do now is based on how we have evolved in the past. And for anybody that's over 45 years old, you'll recognize some of those things, all of which on this picture are included now in the iPhones that we carry in our pockets. Folks think about EMS in the United States as typically starting in 1966 as a result of this National Academies of Science, National Research Council report called Accidental Death and Disability. This was the first time, well, it actually was not the first time, but it was the first time that this type of a report gained significant public attention. Talked about what in both the pre-hospital setting was like and care in the emergency department, and both of them were absolutely abysmal. Ambulances at that time were, and I think Dr. Gross talked about this with his recent program a couple of months ago, but ambulances were typically held and operated by funeral homes. They were the only vehicles that could transport patients lying down. And this gives you a reflection of the quality of care that was provided. Very significant motor vehicle crash, damage to the vehicle, damage to the hood, roof, and windshield. Assuming the patient had a laceration, it was wrapped up. The patient was helped out of the vehicle, likely walked over to the stretcher, which was next to the ambulance, and stretcher was placed in the back of the ambulance. And oftentimes both ambulance attendants would ride in the front of the vehicle without providing any care to the patient while they were being transported to the hospital. Care similarly was pretty wanting in emergency departments because they were typically not well staffed. There was a physician in a community hospital. There was a physician on call who would be called in when somebody would be brought to the emergency room. They typically were staffed by nurses who would do their triage and then call the physicians in. So this report really was an indictment of both pre-hospital and hospital care. The other reason that I want to point this report out to folks, particularly those who have not yet looked at it, is I would encourage you to read it. It's a 27 or 28 page document, not terribly detailed science, but really provides you with a good picture of what was going on at that time in our history. And it's really the first time that we started to talk about EMS. As we talk in a couple of minutes about the various legislative or regulatory authorities, it's important to point out that at the federal level, all federal activities are based on authorities that are given to the federal government in the Constitution. And it's really important to understand that that does not include authorities over public safety and most aspects of public health. There are very few areas in which the federal government can control public safety or or healthcare issues. And as it relates to healthcare, it's mostly with things to do with the CDC. But those are extremely limited. And that'll become important as we talk about some things a little bit later on. All of these responsibilities are delegated to the states, who then have the authority to do so. So as it applies to EMS, the states are really the entity that have the legislative and regulatory authority over EMS. And that can be demonstrated through legislation, rules, regulations. All three of those mechanisms are used by state governments to provide guidance and requirements that apply to EMS. Legislation or laws are generally the highest level of authority, and they're the most difficult to change. But there are some states where all of their EMS authority is vested in legislation, in state law. State EMS offices have the ability to develop rules and regulations, which are a little bit more flexible. They tend to be a little bit more specific in their detail, but they're also more flexible in their ability to make modifications to rules or regulations. All states have an EMS office of some sort. Where it is located varies from state to state. Most of the states, it's included in the health department. There are some states where it's in the Department of Public Safety, the Department of Homeland Security. A couple of states have their own department of EMS, if you will. There's also a comment here made about incorporation by reference. And that occurs when a state makes reference to some specific document. And I'll use scope of practice as an example. Based on what I've said earlier, the federal government doesn't have the authority to define a national scope of practice for EMTs, advanced EMTs, paramedics, or first responders. The Constitution prevents that. It's delegated to the states. Nationally, the NHTSA Office of EMS has developed, with a contract through NSEMSO, a national scope of practice model. That wording is very, very deliberate in that that document suggests scopes of practice for the 4 levels of clinicians. It doesn't mandate it. And it is offered as a model that states can use. The states that in their legislation have specifically said the scope of practice for EMS clinicians in X state is the national scope of practice model. That is incorporation by reference. So that state, by referring to the national scope of practice model in their legislation, specifically says that the scope of practice model defines the scope of practice for EMS clinicians in that state. What that means is, as clinical care change, and the scope of practice model typically is updated no more frequently than every 5 years. Historically, it has been 5 to 7 years generally. That means if a state adopts the scope of practice model by reference, that they cannot change their scope of practice in that state until the scope of practice model changes. Okay, so that's why it's important to understand this concept of incorporation by reference. And then obviously there can also be local ordinances, codes, or contracts which define and have oversight over EMS authority.
Dr. Krohmer,
please, Steve.
Sorry to interrupt. Would you just explain to the people what NSEMSO stands for? A lot of them probably don't understand what NSEMSO is.
My apologies. Yep. NSEMSO is the National Association of State EMS Officials. That is the organization. It is a participatory organization for all state officials, where the state directors, the state medical directors, trauma coordinators, education coordinators, EMS for children's advocates come together and address common issues that the state offices have. So what I was referring to there with the scope of practice model is NHTSA released a request for proposal to develop the scope of practice. NASEMSO bid on that and was given the contract to develop the scope of practice model. I hope that clarifies it.
Yeah, how many states have adopted it, by the way? It was
adopted it by incorporation by reference.
Yeah.
I don't know specifically, probably a half a dozen at the most.
Right. Yeah. There's not a lot of them that adopted it per se in references you're talking about, Dr. Krohmer. A lot of the states will modify that. They'll use it as a guidelines in there and develop their own state specific in there. But what that has done, though, initially when I first started in the state office and everything, there was over 40 different levels of EMS across the United States, and it became very difficult to move from one place to another, where this national scope of practice has helped a lot in aligning those in there.
Yes.
Each one of the states now have a very close reference when you look at an EMT versus an advanced EMT versus a paramedic. There's a lot more similar than there ever has been in the past in there. And most of them use the national scope of practice or the clinical guidelines, as a reference for them, and then adopt their own specific brand, also for the reason that you talked about, that allows them to make a change in the scope of practice more rapidly than incorporating it by reference.
Yep. Thank you, Steve. And I didn't mean to confuse folks with that. It's just important to understand that if you ever hear that there is incorporation by reference, that means that some other specific document is essentially what dictates that particular component.
that was a great example, and I think it'll be important going forward for a lot of people.
Yeah. The accidental death and disability report was released in 1966. The Highway Safety Act was also released in 1966, and there had been some preliminary work done on both of those. They were actually released relatively close to each other from a timeline perspective. But this was the first act that affects EMS directly. It created the Department of Transportation. Prior to that, there wasn't a department. The other thing that I should reflect is the accidental death and disability report focused primarily on motor vehicle crash injuries and mortalities. That was the purpose of the report. The report actually found that you are more likely to be killed in a motor vehicle crash in the continental United States at that time than you were to be killed in the Vietnam War, which had a very significant impact on people. So this Highway Safety Act was enacted. It created the Department of Transportation. It also directed the Department of Transportation to address education and equipment requirements on ambulances. This really is the first time that a federal agency became involved in, at that time, I'll say ambulance because it really wasn't EMS. But it's important to note that this act did not provide any regulatory authority to the Department of Transportation over EMS. And you will find that that's a common theme throughout most of our history, quite honestly. One of the first things that DOT did was to start work on the first EMT curriculum, which was released in 1971. And it's of note that the Department, the Transportation, the precursor to the Office of EMS, and now the Office of EMS was the first and only federal agency that has provided continuous support to EMS throughout what essentially is our history of modern EMS. There's one other thing that's confusing that needs to be clarified, is that when the Highway Safety Act was passed, Congress also directed CMS, the Centers for Medicare Services at that time, which was also only a year old, to provide reimbursement for patient transportation of ambulances, patient transportation by ambulances. They were only concerned about the transportation component of it. Folks are oftentimes confused and concerned now because the de facto lead EMS agency at the federal level is the Department of Transportation. CMS only reimburses with some modifications for the level of care provided, but only reimburses for transportation. That reimbursement is not because of the Department of Transportation Office of EMS's location. They're true and unrelated. The problem that we're faced with EMS right now in its reimbursement is that CMS has never gone back, and Congress has never told CMS to go back and change the reimbursement from based on transportation. Okay. So we've got to get CMS to change their authorities. Then in 1973, the EMS Act, the EMS Systems Act was passed, which created another EMS office in the Department of Health, Education, and Welfare, which is the former name for the Department of Health and Human Services currently. It provided funding support via grants for us to develop 303 regional EMS and around the country, outlining 15 components that we'll talk about very briefly in a minute. But it again is important to understand that this provided funding for grants. The Office of EMS had oversight of the grants, but had no regulatory oversight of EMS. Okay, so common theme here, no regulatory oversight. Unfortunately, in the Reagan administration, they revamped a lot of the funding issues. The funding for that program was terminated in 1980, and the DHEW division of EMS disappeared. These are the 15 components that were included in the EMS Systems Act of 1973. 1973. We're not going to spend a lot of time talking about them, but it really outlines pretty broadly appropriate categories that needed to be addressed for any program that was developed with those government funding. And if you look at this and compare this to the list that was generated in the 1996 EMS Agenda for the Future, they're very similar. As a physician, I've got to do this, but if you look at the Systems Act, there was no requirement for medical direction or medical oversight. There was when we recategorized things in 1996. And then another act that is important just for awareness was the Trauma Care Systems and Planning Development Act of 1990, which created a division of trauma and EMS within the Health Resources Services Administration of HHS. Again, it was a grant program to provide funding to state EMS offices to improve pre-hospital trauma care, particularly with a focus on rural areas. But again, it's important to understand that other than the oversight for the grants, there was no regulatory authority over EMS that was invested in HRSA. That funding lasted for 5 years, and when the funding expired, HHS didn't provide any additional funding, and that office disappeared as well. So where are we now with federal agencies that have some involvement in EMS? These list a couple of them. The major organizations all participate on a Federal Interagency Committee on EMS, referred to as FICOMS. The purpose of FICOMS is to bring all of these agencies together to talk about EMS in the nation, talk about their programs, work together to make sure that there is not conflict in requirements by the various departments and agencies as they're developing EMS programs. So the Department of Transportation, I've already alluded to this, is the Office of EMS. Several components of Health and Human Services that are very active in EMS activities. The Administration for Strategic Planning and Response, or ASPR, works very closely with EMS, primarily on the disaster preparedness and response side. They don't do a lot as it relates to day-to-day EMS activities. Although ASPR is responsible for the hospital preparedness program, which does have a requirement that for all of the regional healthcare coalitions in the country, EMS has to be a participant in those regional healthcare coalitions. I think folks are very familiar with the EMS for Children's program in HRSA, and the Centers for Medicare and Medicaid Services is part officially of the Department of Health and Human Services. The Department of Homeland Security has two agencies that interface with the EMS community, the U.S. Fire Administration and FEMA, and the DHS Office of Health Security, formerly the Office of Health Affairs. And then the Federal Communication Commission also participates in FICOMS. Again, you've heard this several times already, but it is important to understand that none of these agencies, with the exception of the Federal Communications Commission, really has any direct regulatory authority over the day-to-day activities of health and of EMS around the country. Just to talk about some of these activities very, very briefly, the Office of EMS, I'm not going to go through the entire list here, and this is really only a partial list. But much of what you hear being done at the national level is as a result either directly from the NHTSA Office of EMS or as a result of contracts sponsored by the NHTSA Office of EMS. The National EMS Information System, I'll just point out, we've talked about the scope of practice model. Steve made reference to the EMS model clinical guidelines. Hopefully folks are aware that the field trauma triage guidelines were updated based on a contract from NHTSA to the American College of Surgeons Committee on Trauma. Some of the other agencies, I've alluded to this already, but ASPR primarily for disaster planning and preparedness. I'd mentioned the hospital preparedness program, and ASPR is responsible for the Strategic National Stockpile, among other things. The EMS for Children's program, folks, I'm happy to talk more about that if you want more information. Centers for Medicare and Medicaid Services, again, the entity that defines the reimbursement mechanism for ambulance services, EMS services around the country. It is still based, unfortunately, primarily on transportation, with some variation based on the level of care that's provided. But it's important to understand that this reimbursement model was created in the 1960s and has not been updated since then. So as national organizations are looking at changing the reimbursement model, they have to work with CMS. They're also working with Congress. I make this an important point for local folks to understand, because when you become aware of those things, you need to communicate your issues and concerns to your federal elected officials. Homeland Security, we've talked about Fire Administration with their training programs, grants, and guidances. In terms of specific regulatory authority, the Department of Transportation really has very little. If agencies are operating commercial vehicles like semi-tractor trailers or commercial vehicles other than ambulances themselves, they may be required to comply with some of the personnel transportation requirements. Ambulances are exempt from otherwise DOT regulations. There are a number of HHS agencies that do have a regulatory effect on EMS operations. The Public Health Service Act controls clinical laboratory activities. So if you're doing glucose scans, your agency has to have a waiver or be regulatory compliant. HIPAA obviously is one of the regulations that significantly impacts EMS. I'm going to editorialize here for just a second and reinforce the fact that there is a lot of confusion out there about the specifics of HIPAA regulations. When you talk to a hospital attorney or a hospital risk manager and ask them for follow-up information on a patient that you have taken care of and transported to their hospital, the most common response that you get is, we can't give you that follow-up information because HIPAA says that we cannot. That is unequivocally wrong. If you have cared for a patient and transported them to the hospital, you have the right to have access to follow-up information. Now, it gets a little bit nitpicky when you start to look at it, because a quality improvement coordinator for your agency could request follow-up information, but that quality improvement coordinator can only share that specific information with the crew that took care of that patient. So, you can't get follow-up on John Krohmer when he was transported to the hospital for his acute MI and share that information with everybody in the agency. There are restrictions, but no question, HIPAA allows hospitals to share follow-up information on patients for whom you have provided care. If you've got any questions or concerns about that, write them down in the chat. We'll talk about them more. That is, if a hospital risk manager or attorney says they can't share information, they just don't understand HIPAA and they're using it as an excuse. I'm done editorializing. The Food and Drug Administration does have some regulations that affect our administration of medications to patients, and obviously CMS as it relates to requirements for appropriate reimbursement. The Drug Enforcement Administration has regulations that we have to follow as it relates to controlled substances that we use. The Department of Labor has occupational safety and health regulations that we have to comply with as an organization that employs individuals. And the Federal Communication, although they're not significant regulations, does have regulations that EMS agencies have to comply with. So most of the responsibility and authority for EMS comes at the state level, and that is vested in their legislation, in their rules, and in their regulations. And it typically refers to these types of topics. NASEMSO actually has a model guideline for state legislation if state EMS offices are interested in looking at that. There are two things that I want to point out specifically with this. The state EMS offices are required and have the authority to license and potentially de-license EMS clinicians. It's licensure, it's not certification. We are getting to the point where I think most folks understand that, but licensure and certification are different issues. The other thing, again, from a physician's perspective, that's important to acknowledge is that most of the state laws, rules, or regulations also outline the roles, responsibilities, and requirements for EMS medical directors and their authorities to credential individuals or potentially limit their clinical privileges. This schematic was developed as a result of the most recent EMS scope of practice model and just outlines in a graphic way that a clinician's scope of practice depends on the education that they receive and successfully complete. So whatever the training program is and however that's established, their certification depends on some type of most commonly national, although there are some, not too many states that still do their own state examination to certify that the clinicians are competent at the baseline level. Licensure is the state responsibility. The state is the one that gives out the license. And then credentialing is dependent on the medical director and the agency that the individual works with. So you're educated to perform at a certain level. You're certified as competent. This is the National Registry in most cases. You're licensed by the state and then credentialed by the local medical director. One of the other things that is important for folks to understand is generally when you have a license to practice in an individual state, that license only applies to that state that gives you the license. Unless there is a compact in place that allows recognition of privileges in states that have adopted the compact. The easiest example to think about is I have a driver's license that's issued by the state of Michigan, but I can drive in any state in the United States because all states have agreed to a driver's license compact. And there is a law in every state that says if you have a driver's license that's a valid driver's license in state X and you're driving in state Y accepts state X's driver's license. Okay. This project, the EMS Compass, started in 2012 as the replica project, the recognition of EMS personnel licensure interstate compact. And what this does simply is say, if Michigan is a compact state and someone from Ohio, particularly during the time of a disaster, mass casualty event, some type of untoward event, if somebody from Ohio comes into Michigan, then Michigan will accept their EMS license. The compact defines the scope of practice under which the providers are responsible. For example, if I'm Michigan and going to Ohio, I'm still held to the Michigan scope of practice. There can be waivers to that more easily according to the compact. And then the Interstate Commission is just the supervisory commission. It's composed of an individual from every commission state. The other thing that is a part of the compact is recognition and sharing of licensure information between compact states, so that when you move from one compact state to another, you have the privilege to practice in that other state. So these are three components of the EMS compact. Currently, there are 24 states that have adopted the compact. In order to do that, a state legislature has to adopt the compact wording as part of its legislation. So the dark blue there are states that are in full compliance. The light blue are working toward it. And those in white, they have data pending, but not full compliance yet. Those that are in the gray have not yet adopted the EMS compact. There is one other, how are we doing time-wise? We're doing okay. One other really important concept that I want to discuss very briefly with folks, because it's a hot topic right now. Folks acknowledge the fact that law enforcement and fire service are accepted in most states and communities as an essential service, and EMS is not. There has been some clamoring about why doesn't Congress establish EMS as an essential service? The answer to that, as we have talked about previously, the Constitution doesn't allow Congress to do that. The federal government has no authority to designate EMS as an essential service. In fact, the federal government, with very, very, very few exceptions, has not defined EMS or fire service activities as an essential service. That is done at the state and or local level. The other thing that's important to understand is designating a discipline as an essential service doesn't guarantee any funding. All it does is allow the jurisdiction, either the state or the city or the county or the township, to request community-supported funding. They can propose a millage or a tax or whatever funding mechanism is used in that state, but it has to be voted on and accepted by the community. Okay. I hope that clarifies some of the confusion associated with essential services. It is, and I'm not suggesting that we should not go ahead and get EMS designated as an essential service. Just understand that that has to be done at a state or local level, and it doesn't automatically guarantee funding. We have to do additional work to get the funding to support it. EMS was defined described in the 1996 EMS Agenda for the Future as the intersection of healthcare, public health, and public safety. There's a lot of discussion now about whether this is still applicable because EMS is primarily healthcare. There's no question about it. The problem associated with actually, there are two problems associated with this diagram, and we'll get into that. This is just how the NHTSA Office of EMS redesigned the diagram a number of years ago. This provides you with a different schematic saying the same thing. And as you look at all three of these tabs, they're all the same size, which is unfortunate and doesn't represent EMS activities well. I will offer to you that based on my experience with the pandemic for the almost 3 years that I was involved in it, we also need to include emergency management in this intersection with EMS for a couple of reasons. Emergency management doesn't routinely think about EMS all the time. They are now more than they were before. But EMS really needs to be considered one of the critical healthcare partners. It is technically part of ESF8, which is healthcare and the federal emergency support functions, but it's different, and we need to engage ourselves with emergency management. And we need to reflect that our engagement with these disciplines is not the same. We really are providing primarily healthcare services. We are also providing public health services, and I would offer that increasingly we will be providing more and more public health services in the future. There's a lot of controversy about whether EMS is a public safety entity or not. And I will share with you my perspective is we are considered by the community to be part of public safety. You call 911, you typically get police, fire, or EMS. And whether EMS is provided in a fire-based program, it's provided by a hospital-based, a volunteer, or a for-profit organization, the community views EMS as a public safety resource. But as we look at all of these components, we need to understand that we're primarily healthcare, a lot of public health, and that's going to increase. We are public safety, and we need to increase our engagement with emergency management. Those are really sort of the big things that I wanted to point out. Probably the biggest take-home message is in spite of what we might hope, the federal government really does not have the authority to regulate in the sense that most people think of as regulation, EMS activities. That resides at the state and local level. The other thing that is reflected in this slide is the work that you all do on a day-to-day basis is just absolutely critical. EMS clinicians have really been tested over the course of the pandemic. I would offer that we have not yet recovered from the pandemic. And we need to support each other, but you all need to acknowledge the critical role that you play in your communities and really be appreciative of that. I'm going to stop sharing now. I think we still have a little bit of time. I'm happy to clarify any of the points that I discussed, or if there are other topics that folks have added. I'm open to almost anything.
I got one.
Go ahead, Will.
Dr. Krohmer, you mentioned several times that the federal government, provides guidelines and grants and a bunch of stuff, but when it comes down to how things function at the street level, it becomes a very different issue. Do you think that's probably because of our basic structure as a government, as a republic? The states' rights are first and foremost in a lot of issues, and they have the right of self-determination to some degree.
Yeah, I think you're spot on, Will, and not probably that definitely is that, because we have at the time I was in the office of EMS, we had representatives with folks in Congress about some of these specific issues, and they are very clear and very hard, fast in that the federal government does not have the authority to do those types of things.
I remember we would go to the Hill, like a lot of public safety. We all have our day on the Hill, and invariably, our senators and congressmen would say, "We support you. We can work on legislation, but if you're looking for money, you're going to have to go to your state officials. You have to go back home."
Well, and there's a lot of controversy about that, because to a certain extent, that is a little bit of a cop-out.
Yeah.
Because the federal government can provide support programs and funding to support state and local activities. They're typically in the form of grants. The federal government will establish what the requirements are for applying and complying with those grant requirements. They can't do they can't do something directly to an individual agency. It typically has to go to a state entity or a regional entity, regional health departments, healthcare coalitions, and things like that.
Thank you.
Dr. Krohmer, as a previous state official and everything, I will say, I think I've had the privilege of working with 6 different directors in the Office of EMS in my tenure. One of the things that I've really recognized and everything, and as a state official and everything, is the leadership that NHTSA has provided in helping to make a more cohesive national EMS agency. And I think that that's gone a long way, and the partnership in there. Well, people understand that you just don't sit in your office and come up with these, grandiose things and everything. You partner with the people that provide that, be it the National Association of State EMS Officials, the National Association of EMS Educators. You bring in the right people to do the right job in there. And I think that that's missed a lot sometimes in there, that it's not just dictated by NHTSA in there. They gather the right people and come up with the right answers to a lot of solutions. And I think a lot of state offices look to to the NHTSA for their leadership in there to help ensure that public safety or the public health care is being met in between there. So again, I commend you with a lot of that. As I was working in the state, it was very, very nice to be able to see those changes and everything and work in that direction.
Well, I appreciate that, Steve. Obviously, I have a biased perspective, having spent over 5 years there. I will. I've got to compliment the folks that are in the Office of EMS. They're extremely talented individuals, with the exception of one. All of them are at least prior EMS folks. Several of them are still doing clinical shifts in the field. I will also acknowledge, however, that the other federal agencies that are involved in EMS also have folks with real world field experience that they bring to the federal perspective. And, the agencies that I outlined, particularly ASPR, the EMS for Children's program, the U.S. Fire Administration, and the Office of EMS, they're talking to almost every day. They're talking to each other about various issues. I should also acknowledge that many of the programs that I mentioned that the NHTSA Office of EMS sponsored and gave contracts out were also by the EMS for Children's program at NHTSA. So many of those national programs are jointly OEMS and EMSC programs. The one thing that I will mention as it regards to authorities, and I alluded to this, but the reimbursement mechanism that EMS is still faced with is based on authorities that Congress gave to CMS. And it's my personal perspective that Congress will have to change those authorities for CMS to modify their reimbursement model. So those of you that are out in your communities, any and every opportunity that you have to share with your elected leadership, they need to know that the current reimbursement model is at least 40 years out of date based on almost 60-year-old authorizations. And I can say that now as a former Fed. I couldn't say that before as a Fed.
Right, but it's an important issue, though. Reimbursement is back to what you were talking about with essential services and everything. There's not a single person that I think that will disagree that EMS is not an essential service. The issue is the funding that goes along with it to continue to support that and everything.
That's correct.
We're still in an existence where 70% of the EMS providers are volunteer.
Yep.
There. And it's become an expensive thing. And EMS is being asked to take on more and more tasks on a daily basis, almost in between there, and I think the pandemic was another classic example of it. And, there's always been talk about maybe the name needs to change. Maybe it's not emergency medical services as more as out of hospital services in there, as you alluded to, because that keeps getting bigger and bigger as the hospitals, we're seeing sicker and sicker patients at home than what we've seen in the past. And EMS is that safety net is alluded to in there and the EMS agenda for the future. So again, I think we're going to see a lot of things change in the future.
I can tell you that the essential services issue is doable. There is
Yeah.
a county in eastern Michigan that a year ago passed a 5-year, $3.5 million millage by an overwhelming majority to support only their countywide EMS agency.
I think we have 3 or 5 counties now in the state of Iowa that have been able to do that. And but the one thing too that people have to understand is that just because they vote on it once, a lot of them have a sundown issue in there that they have to vote on it at somewhere between the 3 to 5 year to reenact that.
Yep.
I know we're nearly out of time here, but
Yes.
we're going to do one question. A lot of our audience here is rural, as you know, Dr. Krohmer. The group that we collect is across the breadbasket part of the states largely. And there's been a lot of stuff in the press lately about increasing training levels and degree programs for pre-hospital care providers. And in the rural areas, they're having trouble getting people to staff, their communities. And do you see any kind of a conflict between the struggle to get people into EMS and on the other end, taking on more responsibilities in the communities, like being the healthcare provider of last resort, and we barely have enough bodies to do the job? Are we going too many different directions at once potentially? Just something I think about. Now I dumped it on you.
Yeah, I mean that is a loaded question, and will take a long time to sort out. I am a very firm believer in the scope of practice model and the particularly at paramedic level, the accreditation issue and national registry. Having said that, there are, and this has been reinforced many times over with the pandemic, there are alternative education models that can very easily be employed to accomplish the requirements and be compliant with the regulations. We just need to figure out how we can get those out where they need to be.
And I think that's a tough balancing act. And again, back to what you talked about, when you pick up the phone and you call 911, you as a citizen expect a minimum level of care that's going to be able to be provided. And that has to be the standard in between there. And unfortunately, education, it's tough to continue to lower the bar than there to meet those requirements.
Yeah, there is no simple answer. Sorry.
Yeah, it's interesting to see this discussion. And as an emergency physician, you guys know you were the safety net for communities that had no primary care. And
so is the EMS system.
Now it seems like they're even extending that further, that we're going to train EMS providers to play a bigger role in their communities. That sounds like a large non-transport community care kind of thing. And
well, and I don't want to beat a dead horse, but a lot of the problem with community paramedicine, mobile integrated healthcare, a number of other models like that is the reimbursement. And we're hosed right now because you can't get reimbursed generally unless you transport the patient. We have to change that model. And if we go to Congress and we get them to change the CMS reimbursement model, all of those things have to be included. Rural communities need to be able to get reimbursed for clinical care that they provide without transporting the patient an hour and a half to a critical access hospital.
Yeah, they did it for physician extenders, so why it's time they did it for EMS as well. I would agree.
Yep.
Okay. Again, as Will pointed to and everything, that we're getting a little short here on time. Let me see.
Yeah, I just saw a comment there about it extends from EMRs to emergency physicians, emergency nurses. You're right.
Yeah, it is. There's no healthcare in and by itself is suffering in a crisis right now. in there, especially those that do the emergency care in there. And like I said, not a good answer. So again, Dr. Krohmer, I want to thank you again for all of your knowledge and all of your assistance and everything that you've provided throughout the years here. And thank you for being with us this evening.
Dr. Krohmer, again, thanks particularly for letting me throw a couple hand grenades out there at the end of the presentation.
Not at all. Thank you for the invitation. I know it wasn't clinically oriented, but it's important stuff that we need to understand.
This is your organization. We have a mission to serve pre-hospital care providers, and we have no other agenda. So if you like what you're seeing here and you have the ability to support the foundation, again, whether it's a buck or whether it's more, we use that money to fund the activities of the foundation and the McSwain Trauma Education Project. We do it because we love it. Everybody you see here today is committed to that mission. And I want to thank you all for coming, because it's like you can have a mission and you can want to do cool stuff, but if nobody shows up, you're failing. So thanks for making us successful. And we'll keep bringing you stuff here and everywhere else that we touch. Thanks again, everybody.